The stressors I just covered can provoke stress response from several different organ systems listed here. I will cover each of these in the next few slides. First, psychological stress response can result from acute or chronic stress. How we respond psychologically to stress can have physical manifestations in our behavior. For example, we can grind our teeth, bruxism, or clench our jaw, leading to temporal mandibular jaw problems. We may seek out to self-medicate ourselves, alcoholism, drug use, eating disorders, or worse, have suicidal ideations. We can feel anxious and respond inappropriately to basic stimuli. Muscle tension can build, which can also lead to migraines, headaches, or even have profound behavioral changes as seen in post-traumatic stress disorder, or PTSD. Cardiovascular stress responses are a result of the epinephrine targeting the blood vessels through stimulation of the alpha-1 receptors, and also through targeting the heart by stimulating the beta-1 receptors. As a result of targeting these receptors, heart rate, or chronotropy, and force of contraction, inotropy, would increase. And stimulation of the alpha-1 receptors leads to vasoconstriction. All of these events would lead to hypertension. 90% of hypertension cases are considered, quote, essential, which is a fancy way of saying primary hypertension. When we say primary hypertension, we recognize that the patient's mean arterial blood pressure is greater than 110 millimeters of mercury, but we are not sure of the exact etiology of this problem. I'd like to cover just a bit more on hypertension, and perhaps this is mostly review for you, as you probably covered much of this in your regular physiology course. You can find this information in your textbook as well. Of course, mean arterial blood pressure isn't a true mean or average. The heart is in diastole longer than systole, and thus when we calculate mean arterial pressure, or MAP, we adjust our calculation to give more weight to the diastolic pressure. An ideal blood pressure reading is slightly below 120 millimeters of mercury for systolic pressure and roughly 80 millimeters of mercury for diastolic. If a patient has a systolic pressure of 120 to 139 and a diastolic pressure of 80 to 89 millimeters of mercury, let's say, the patient is considered to be prehypertensive. If the patient has a systolic blood pressure of 140 and a diastolic pressure of 90 millimeters of mercury, this is most certainly considered to be hypertensive. Obviously, you should be noticing that hypertension is an elevated systolic and/or diastolic pressure. And essential hypertension is an elevated blood pressure without any other disease present that could cause the elevated blood pressure. In secondary hypertension, a patient has high blood pressure, but the cause is known. Some other disorder or disease is the culprit. The pathogenesis of essential hypertension could be familial or genetic, race, and even age-related factors. We also know that there are lifestyle risk factors, for example, smoking, high salt consumption, obesity, and stress. Speaking of stress, which is the focus of Chapter 9, studies show that acute stress has a greater impact on causing hypertension, but chronic stress doesn't seem to cause the chronic hypertension. The dangers of hypertension include stroke, myocardial infarction, coronary artery disease, kidney disease, retinopathy, etc. According to your book, hypertension can lead to dementia and impaired cognitive ability. The hypertension can lead to ischemic stroke and intracerebral hemorrhaging. The narrowing of the blood vessels to the brain leads to hypoperfusion, that's ischemia, loss of autoregulation of blood flow by the surrounding tissues, And of course, we remember the chemical signals released from a tissue bed that should cause vasodilation of the upstream arterial and precapillary sphincters serving a capillary bed include acids like hydrogen and carbon dioxide, warmer temperatures, potassium, and adenosine, just to name a few. That's all I will cover for now regarding hypertension, but we will discuss this topic at a later date. Immunological stress. When it comes to immunological stress, Zellier in his triad of responses to stress noted there was thymic atrophy, a decrease in thymus size. T cells are matured in the thymus and are part of our cellular defense mechanisms. B cells are matured in our bone marrow and are part of our humoral defense mechanisms. The glucocorticoids that are released in response, for example cortisol, depresses the maturation and selection process for both B and T cells. Therefore, fewer T and B cells are present in the blood. Of course, clinically, we can appreciate physician-induced hypercortisolism, where a patient, say a patient who has had an organ transplant, would want a suppressed immune system to decrease the chance of rejecting the new organ. The reduction of B and T cells can result in asthma, allergies, rheumatoid arthritis, and possibly even cancer. There are also gastrological stress responses. I'll remind you that the gastric mucosa has many intrinsic protective factors, such as high mitotic turnover due to an abundance of growth factors to replace the surface columnar epithelial cells, bicarbonate-rich mucus, which buffers the cells from the high acidity, and prostaglandin PGE2 also protects the gastric epithelium from the acidity, just to name a few. Chronic stress disrupts these protective mechanisms and leads to gastric and duodenal ulcers. In the case of gastric ulcers, the problem arises from a decreased ability to withstand the high acidity. The protective factors are lost. In duodenal ulcers, the primary culprit is an increase in acid and pepsin release by the gastric mucosa. If you remember your physiology, you might recall that there are three mechanisms for acid production: histamine, vagal stimulation, and gastrin. When all three are used, there is much more acid production than predicted by just summating the three individually. This is a process called potentiation. It is interesting to note that when a patient has a gastric or duodenal ulcer, and we have ruled out other causative agents like alcohol, smoking, or aspirin use, the primary culprit turns out to be a bacterial infection from Helicobacter pylori. Now, our stress theme fits in here too. We just covered the fact that high cortisone leads to a decrease in B and T cells. This would render a person more susceptible to bacterial infections, even by H. pylori. We will cover H. pylori-induced ulcers at a later date. In stress, the neuroendocrine response is a combination of the fast-acting nervous system and the more long-term activity of the endocrine system. There is redundancy in these two corrective mechanisms, and they very much augment each other. The manifestations of the stress response are strongly influenced by both of these systems. Your textbook is certainly correct when it states that the integration of the components of the stress response at the level of the central nervous system is complex and not completely understood. We know the cerebral cortex has a role and layers below the cortex or subcortex, and even the cerebellum for detecting the degree of flexion and extension across joints, basically stress of the joints, the brainstem components, for example, medulla and pons, the diencephalon, that is the thalamus, epithalamus, and hypothalamus, the pituitary gland, the components of the limbic system, and the reticular activating system are all involved in the stress response. This is just to highlight a few. And to go through them, just to highlight a few, the cerebral cortex is implicated in maintaining vigilance, cognition, and focused attention during times of stress. The limbic system tries to manage the emotional aspect of stress, the fear, the anxiety, and even anger during a stress response. The thalamus serves as a relay station where it receives incoming or afferent action potentials and sends output or efferent signals to the appropriate part of the brain. The hypothalamus coordinates the endocrine and autonomic nervous system during the stress response. Regarding its role in the endocrine response, the hypothalamus is part of the HPA pathway, which I will discuss in just a moment. For the autonomic nervous system, the hypothalamus plays a huge role in activating the sympathetic nervous system and even targets the adrenal medulla. The reticulating activating system, or RAS, helps to maintain mental alertness. As a side note, the RAS is responsible for arousal from sleep and also helps you to mute out background noise, like when you study with music on or in a busy Starbucks coffee shop. The limbic system stores memories that will help you avoid the stressors in the future. Adding to all this complexity, as shown here in this figure, is the fact that individual brain circuits do not function in isolation. There are many diverging, converging, and even reverberating circuits at play. The locus coeruleus is part of the brainstem and is also a portion of the brain that targets the adrenal medulla to release more epinephrine. The adrenal medulla first makes norepinephrine and then converts about 85 to 90% of this to epinephrine, which is then released into the blood as a hormone. This locus coeruleus and adrenal medulla are heavily engaged when there is a sensory stressor that provokes the survival, behavioral, acute stress response, that is, the flight or fight response. The locus coeruleus norepinephrine response is the most rapid response of all the stress response mechanisms. Of course, we associate the pounding heart, dilated pupils, sweaty palms, and increased ventilation rate and depth with this type of response. And we know these physiological changes are caused by the epinephrine stimulating receptors on these target organs. Let's change focus a bit. In this picture, you can see the limbic system sends signals to the hypothalamus. The hypothalamus participates in a neurological response, as I mentioned before, by stimulating the sympathetic nervous system. But the hypothalamus also participates in the endocrine mechanisms in the stress response. I will continue this on the next slide. This hormonal part of the stress response would occur during the resistance phase. The hypothalamus releases corticotropin-releasing factor, or CRF, also known as corticotropin-releasing hormone, CRH. The CRF travels in the bloodstream through the hypothalamic hypophyseal portal system to the anterior pituitary. In turn, the anterior pituitary releases adrenocorticotropic-releasing hormone, or ACTH. In turn, the ACTH targets the adrenal cortex, specifically the zona fasciculata, which in turn releases glucocorticoids such as cortisol. Cortisol will augment the action of epinephrine released by the adrenal medulla. Both hormones, cortisol and epi, are antagonistic to insulin and will cause blood glucose levels to rise. We say these two hormones have diabetogenic effects. Cortisol will also impair any non-essential function in the body during the stress response. For example, if you were under severe stress as a child, your growth hormone and response to growth hormone will be impaired. As a result of the chronic stress, the child may have reduced stature. The reproductive system is another non-essential function, and this explains why some infertility cases are attributed to stress. Increased cortisol levels also disrupt the HPT pathway. In this pathway, the hypothalamus releases thyrotropin-releasing hormone, or TRH, and this causes the anterior pituitary to release thyroid-stimulating hormone, or TSH. which in turn causes the thyroid gland to release thyroid hormone, TH. Thyroid hormone has many functions in the body, but one worth mentioning here is that it increases metabolic rate. High levels of cortisol reduce the amount of TSH that is released, and in turn, a person's metabolic rate decreases from too little TH being released. This partially accounts for why many people gain weight when they are stressed. Cortisol has other functions in the body besides suppressing the immune system and metabolic rate and non-essential body functions. It also mobilizes lipids from adipocytes and tells skeletal muscle and adipose tissue to spare glucose consumption. This is why cortisol is often called a glucose-sparing hormone. These tissues utilize other metabolites for fuel, such as fatty acids and proteins. As a result, the person with high cortisol levels will present with muscle wasting, particularly in the limbs. Additionally, there is abnormal fat deposition in the abdomen and in between the scapulae. The liver is also targeted, and some amino acids the liver is also targeted, and cortisol causes the liver to engage in gluconeogenesis, which means the liver will use fatty acids and some amino acids to make new glucose molecules. Through both glucose-sparing mechanisms and through gluconeogenesis, the blood glucose levels will rise, and this is why cortisol is considered diabetogenic. Glucose is the primary fuel source for the nervous system. Therefore, during times of stress, when the CNS has more vigilance and cognitive function, you would want adequate amounts of fuel present for neurons. In the HPA pathway, ACTH is released by the anterior pituitary. ACTH is needed for the zona glomerulosa to some extent to synthesize and release aldosterone from the adrenal cortex. Aldosterone causes more sodium and water retention, and this contributes to the high blood pressure seen in people with stress. The hypothalamus also releases other hormones that can contribute to higher blood pressure, like ADH, also known as antidiuretic hormone. ADH targets the medullary duct cells in the kidney and causes more water reabsorption, and this too contributes to increased blood volume and pressure. The next set of hormones I want to discuss in the neuroendocrine pathway in response to stress are the hormones involved in the RAA pathway, which stands for the renin-angiotensin-aldosterone pathway. The juxtaglomerular cells in the juxtaglomerular apparatus found in the kidney make and release renin in response to low blood pressure from low effective circulation volume, shown here in the purple box, or in response to sympathetic command. So let's start with the sympathetic command. During stress, the sympathetic response is more in control. This leads to release of renin by the juxtaglomerular cells. Renin cleaves a constitutively expressed plasma protein called angiotensinogen, which is made by the liver, shown in the bottom left square. The suffix -ogen tells you this is a protein that is made in an inactive form. Angiotensinogen is cleaved by renin into two parts, one of which is called angiotensin 1. Angiotensin 1 travels in the bloodstream to the lung capillary beds. Associated with the endothelial cells is an enzyme called angiotensin converting enzyme, or ACE. ACE cuts angiotensin 1 into two parts, one of which is called angiotensin 2. Angiotensin 2 is an agent that causes vasoconstriction, so it contributes to the rising blood pressure seen during stress. But it also causes the release of aldosterone, which leads to more sodium and water reabsorption, and also contributes to increasing blood pressure. Less recognized by students is that angiotensin 2 also stimulates the release of ADH, seen here in the blue box under the hypothalamus as AVP, or arginine vasopressin, which will also cause more water reabsorption by the kidneys and hence higher blood pressure. ADH, also known as AVP, release also accompanies the thirst reflex, which will lead to more water intake and help elevate blood volume and and pressure. This is a table from your textbook that summarizes all of the hormones that I just covered, giving you the hormone origin and physiologic effects. I would like to remind you that hormones are released by endocrine glands and are chemical signals released directly into the bloodstream. Only cells or tissues with a functional receptor for the hormone will respond to that chemical signal. A few slides back, I listed the three main categories of stressors. I discussed the fight or flight response during sensory stressors, the cognitive stressors, and the sympathomimetic stressors. What I would like to discuss now is the concept of one person's stress can be another person's walk in the park. There's a lot of perception involved in determining what is a stressor, and this perception of what is a stressor varies from person to person. Stressors produce different responses in different people, or even in the same person at different times. And we have different types of ways to adapt. Adaptation is the ability to respond to the challenges of a physical or psychological disruption of homeostasis and to return to a balanced state. The conditioning or coping factors that allow a person to adapt can be internal, like genetic components, or external, for example, coming from social resources like family support. The relative risk for developing a stress-related pathologic process, like PTSD, is partially dependent on these conditioning factors. Let's expand on these factors more on our last slide. On this slide, I'm showing you a picture of Elizabeth Banks working herself through a heart attack. It's a cute video to stimulate awareness of heart attacks in women, as they are a population that will deny that anything is wrong. I encourage you to watch this cute video, and I suspect it will resonate with many of my working professional students who also have busy family lives. If you watch the video, pick up on the signs and symptoms she gives regarding her changing physiology. The organization that sponsored the video is called The Woman in Red. Also, while you are watching the video, pick up on any clues you might get on her ability to cope with this stressor. Internal conditioning factors would include your genetic endowment, gender, and age, just to name a few. External factors include time. How quickly was the stressor put upon us or you? Was it slow to evolve? If yes, we may have more time to develop more conditioning factors. If it was quick to precipitate, we may be less equipped to adapt. Your physiologic reserves refers to your body's organ systems to increase their function during a time of stress. Sleep-wake cycles are conditioning factors. The better quality of sleep you get, the more alert your brain is, and the better its capacity to function through time of stress. We will discuss sleep and sleep disorders towards the end of the semester. How hardy are you during stress? Do you feel like you have control over your stressor? Or do you feel like you are at the beck and call of life's stressors? This would be another internal conditioning factor. Do you feel like you have a purpose in life to get you through this stressor? Do you view your stressor as a means for personal growth and view it in a positive way? There are external psychosocial factors. For example, if school is a stressor, do you have parents that support you monetarily and psychologically? Do you have friends? Your book goes on to describe health status and nutrition as being more conditioning factors that would help with immune responses, wound healing, cardiovascular responses, making appropriate choices, etc. Well, this concludes our lecture on the stress response. It's hard to believe we are almost finished with week 1.